So welcome to Bilmet Ultrasound Training Institute. Today we are taking a question and answer session for our registered candidates. Please make a note that this is a question and answer session for our candidates who are undergoing different server-based courses. This is not a course, whatever we are taking right now, but a question and answer session for those who are taking different server-based courses. So today we got some questions from our registered candidates. First question is from Dr. Papu Kumar, how to identify a fibroid. Second question from Dr. Tempusano Anuk, the presence of pericalosal artery on Doppler can rule. These are the copy pasted questions. These are pasted as we have got it on WhatsApp. We have copied over there and we have pasted. So the language is original over there. Whatever we pasted it over here. So the second question is that the presence of the pericalosal artery on Doppler can rule out corpus callosal agenesis. Now, can the same be applied for partial agenesis of corpus callosum, or is there any way to diagnose partial agenesis of corpus callosum in ultrasound? The third question from Dr. R.C. Sharma is that kidney findings in nephritic syndrome and pyelonephritis. The fourth question from Dr. Tanya is that want to watch more pics on PVS scan, that is, I can identify ovaries, cervix as a whole, as well as picture about adenomyosis and fibroid on PVS. Dr. Tanya. Then the last question is VMOL and GTD have not been explained in early pregnancy. I am not understanding. So actually this VMOL and GTD is not there on server. What we will do, we will take a separate class on this, not in the question and answer session, because this question and answer session is always very brief because we are replying to the questions only. This VMOL and gestational trophoblastic disease, we will have a class and we will update you about this class. So we will quickly take these questions, whatever we have discussed. So we will take one by one. So I am announcing if anybody is having any more question, he or she can raise the hand, not the physical hand, but there is a option in more to raise that digital hand. Once you will raise the digital hand, we will send you unmute invitation and we will discuss one-to-one with you. So starting the session now. Wait,
on how best
first of all, can I have a name?
That angle of insinuation.
Can I have a name, doctor?
In
what is your name, sir?
Dr. Abdi Wahab Mahmoud there.
You are from which city? You are from which country?
Yes, from.
You are from which country?
North Korea.
North Korea. Okay. Now, please tell me
Kenya.
what is your question. Yes, Dr. Deer. Please tell me your question. Quickly. Dr. Deer, you there? Please tell me what is your question.
Yes, I come back on my question.
Yeah, please repeat. Please repeat your question. Yeah, Dr. Deer. It looks that you are having some network issue. What I will suggest you to post your question on the WhatsApp. I will entertain your question. Dr. Neha, I am sending you an invitation. Dr. Neha, I'm sending you an invitation. Dr. Neha, you have to accept the invitation. Hurry up, please. Dr. Neha, unmute invitation has been sent to you. You have to accept the unmute invitation.
Hello.
Yes.
Hello.
Yes, you are audible.
Hello, sir. Dr. Neha is here.
Yes, tell me your question.
Sir, my question is that how can we differentiate either it is TOA or solitary ovarian pathology?
Okay, got it. So I am repeating
And
your
sir,
question.
and sir, one more.
Let me
Does
repeat your
the
question first. I will take your second question also. So the first question from Dr. Neha is that how to diagnose a TO mass and how to differentiate a TO mass, whether this is TO mass or this is an ovarian mass, right?
yes, sir.
Next
Yes,
question.
sir. Does it give a difference in treatment modality if mistakenly
We are not discussing here. We are discussing the diagnosis. So we are not discussing a gynecology over here. We are discussing
No,
radiology.
sir. Sir, I want to ask if mistakenly we give diagnosis TOA as a ovarian pathology in ultrasound report, so does it make a difference in treatment modality?
Anything else?
No, sir.
Okay. Meanwhile, I got the question from Dr. Deer, who was from South Africa, probably, that angle of insonation. Please clear the angle of insonation. What is this angle of insonation? Okay. So these were additional questions. Now see, these were additional questions. We have so the first question, Dr. Papu Kumar, how to identify a fibroid? If Dr. Papu is online, I would like to unmute his microphone. Please come forward, Dr. Papu. Now see, these things, how to identify a fibroid, what is a fibroid, how to identify a fibroid, we have discussed and we are discussing in our courses. What I mean that we are having a server-based course. I am 101% sure that this Dr. Papu has not completed yet a gynae ultrasound course, because this fibroid, how it looks, how to diagnose it, what are the types of the fibroid, how it looks on ultrasound, everything is in detail in gynae and ultrasound course. So in gynae ultrasound course, everything is in detail. This Dr. Papu is not yet, has not yet touched the gynae and gynae ultrasound. I am telling you with 101% assurity that he has not even touched the gynae ultrasound. He is probably somewhere in the physics and machine setting. That is why I am having this assumption, because this thing is in great detail in gynae ultrasound. Now, as I have got the question, I will entertain this question, how the fibroid is looking like. Now, first of all, the fibroid. Fibroid, first of all, I will not show you here slides. We will not draw this because everything is there in gynae and ultrasound course. Gynae course. First of all, the echogenicity. Usually, the echogenicity is hypoechoic. I'm repeating, usually echogenicity is hypoechoic. Note it down. Second, there can be calcifications, random small calcifications, or there can be a big calcified foci in case of a fibroid. And if there is a calcified ring, peripheral calcification, egg shell calcification, that is going in favor of fibroid. And on putting a color, the fibroid will take color not more in the center, but it will be around it. So there will be a ring of vascularity around the fibroid. So I am repeating again, hypoechoic, calcifications can be there, calcified foci, I will say, not small random calcifications, calcified foci can be there, and there can be eggshell calcifications, and on putting the color, we can see that there is a ring of vascularity around the fibroid. This is differentiating the fibroid from an adenomyotic patch. This is one class in our server. That how to differentiate a fibroid. On fibroid, we are having about 4 classes. And how to differentiate a fibroid from an adenomyotic patch, there is a separate 25 to 30 minutes class on server. So I will request you to go to the gynae course, complete it, you will get more clarity. So there are types of fibroids. You know that. Now let me show you some slides of fibroid. So I will show you some slides of fibroid. Now this is the same PPT which we are discussing in gynae ultrasound course. I again am 101% sure that Dr. Papu probably has posted this question, that Dr. Papu has not even touched the gynae and gynae ultrasound yet. So let me go to the fibroid first. 79 179. Now see, these are all slides which are taking about 5 to 10 minutes on each slide to discuss. So this gynae ultrasound course is about 20 days on our server. 20 days on our server. So I am going directly to fibroid. $179. Yeah, here it is. So here the point is that first of all, I told you that we are having different types of, we will not discuss it over here because this is already on the server. Once you will go to the gynae ultrasound, you will find many classes on fibroid in sequence over there. So now see, I told you this is hypoechoic. So this is the fibroid over here. Usually this is hypoechoic. In comparison, it is hypoechoic. I told you on putting a color, it will not take color in the center, but it will take a color from the contours, Now there are different types of these fibroids. There is grading also. There can be degenerative change in the fibroid. These are the degenerative change. I told you there can be calcifications, and especially if these calcifications, the eggshell calcifications, if seen, is very much specific for fibroid. Now, then we have to differentiate this fibroid from the adenomyosis, which we are taking in great detail on our server. So I hope that I have briefly replied to Dr. Papu's question, and again requesting all of you to complete the course, whatever you are posting. For example, you are posting a question from physics and machine settings. First, complete the physics and machine setting, then post the question, because maybe that your question is already answered over there. And some candidates are not even touching the gynae ultrasound, not touching even the fetal, and posing the question. So please, I am requesting again, pose questions from the course which you are undergoing or completed. Now the second question from Dr. Tania. Now I am having a printout over here of these questions. Now the second question from Dr. Tania is that how to identify ovary, cervix on whole, and pictures of adenomyosis and fibroids on TVS. Now see, we are right now, we just now touched the fibroid. Now see, this is the adenomyosis. Dr. Tania wants to see the pictures of adenomyosis. In adenomyosis, what we are having a patch over there in the myometrium. This patch can be seen in ovary also. But the point is, if you see one patch here and another patch there, what I mean by here and there, one patch in myometrium and another adenomyotic patch, that will not be an adenomyotic patch. Now that will be a chocolate cyst over there. So the point is, if there is adenomyosis on the top, there is endometriosis also, that adds on to a diagnosis. So this way, see, in adenomyosis, Dr. Tanya, in adenomyosis, not only I will be seeing a patch, I may see a loss in endomyojunction, which is very much characteristic. So we are having a class on server how to differentiate an adenomyotic patch from a fibroid. Now coming to the second part of the question that Dr. Tanya is posing about the TVS. So let me go to the TVS. These are the slides from the course only. So she wants more clarity on TVS scanning. Now see, this is a picture here of a transvaginal scan. Let me zoom on this. This is the picture of TVS. A very important point. When you are scanning on TVS, you may not see whole of the uterus in one slice. I'm repeating. You may not see whole of this of the uterus in one slice. You may see fundus and body, and at that time you may be missing the cervix. And when you are seeing the cervix, you may be missing the top, because uterus is not in one straight line. It is neither horizontal nor this is vertical. I mean that this is not in a straight line. It is a curved structure. And if it is a curved structure, I will see only one part. So don't expect, first of all, don't expect whole of the uterus in one slice, especially on this TVS. Now here, what I am having a bladder over here, which will be this side. Now, first of all, make a habit of waiting a patient. Make patient wait for at least 5 minutes. What we people are doing, we are asking the patient to empty the bladder and straightway lying onto the bed. No, wrong. Because I want some bladder for orientation purposes. And if patient will wait for a couple of minutes only, so meanwhile, you can scan the next patient. So if patient will be having a minimal bladder, a small bladder, that is for orientation purposes. What for that orientation is, if bladder is this side, if that small bladder will be this side, fundus has to be on the same side. I am repeating. If bladder is this side, not in this tail. Why? Because this is the tail. I want to show you here the uterus. If you got the bladder on the right side, for example, this side, the fundus has to be this side only, then only it will be not a retroverted uterus. And if this fundus is like this side, and bladder is on this side, then it is away from the bladder. That way you can say that this is a retroverted uterus. This is how you can make a diagnosis on TVS whether I'm dealing with an anteverted or a retroverted uterus. Point number second. Now see here, this is a transabdominal probe. Transabdominal probe, bladder, and this fundus. This fundus will be dropped towards the rectum in case of a retroverted uterus, and that way the bladder and the fundus will be on the opposite side when I am doing TVS, when I'm scanning on TVS. Now see, like this. This is the uterus which is dropped. By dropped, I mean this is a retroverted uterus. Here, the fundus will be this side and bladder will be on the opposite side. So this is first point. Not that were 2 points. These were 2 points. Now see, this is the uterus. This is the uterus. Uterus is not like this. Uterus is curved structure. Is a curved structure. Ultrasound cannot pick a curved structure. Cannot take a, what I mean by pick, cannot take a curved slice. Ultrasound is always and always taking a straight slice. What is slice? Slice is from top to bottom or from right to left. So what is meant by a slice? Slice means that I am taking one slice of the organ. Now, is it possible to take a slice of this seed? No. What ultrasound will do? Ultrasound, this is the slice. This is the slice. Now see, this is the slice. It will take a slice of this part, but this thumb will be missing. And if I will be taking a slice of this thumb, this curved structure, this board structure will be missed. Same is the uterus. Uterus is also a curved structure. When I am inserting a probe, TVS, Dr. Tania, when I'm inserting the probe, I may be cutting this way, thereby what I am saying, fundus, body, and this thumb will be missing from the screen. This cervix will be missing from the screen. Once I will be cutting through the cervix, this top and the mid part will be missing from the screen. Clear? Now, second important point on TVS. When I have to scan the cervix, I have to tilt the probe posteriorly. I will say inferiorly, not posteriorly, inferiorly, and I have to pull it slightly out, not completely, slightly out. Then I have to angle it inferiorly. Then only I will get the cervix. Again, repeating. Once I got a fundus and the body on the monitor while scanning on a TVS probe, what I have to do? I have to pull the probe slightly out and I have to angle it inferiorly to get the cervix. And once I have in cervix, now scanning the cervix, what I have to do? I have to now elevate the probe and I have to insert it a bit deep. And once I got that slice from fundus and the body, what again I have to do to go to the cervix? I'm repeating now. What I have to do? I have to pull the probe, not completely out, slightly out, and I have to angle it posteriorly. This is the trick. So I hope that Dr. Tanya has got the questions, the answer to that question. Now, what is the next question? Dr. Temfusano Anok. The presence of the pericalosal artery on Doppler can rule out the pericalosal artery. Let me show you the question. I'll show you the question. So the question, actually, I'm not able to get the slide of the question. I will try to get the slide of the question. Not this. So the question is that in partial agenesis of corpus callosum. So the question is that in partial agenesis of corpus callosum. Probably I will get it now. Let me check. Yeah, got it. This is the question. In partial agenesis, now see, in partial agenesis, this is the question, very lengthy question. So I'm summing up the question. In partial agenesis, how to diagnose the partial agenesis of corpus callosum? Dr. Anok, first of all, yes, you are getting it rightly that pericalosal artery others may not understand this because they have not yet completed the fetal ultrasound course. We are taking detailedly these courses over there on server. This candidate has probably completed the fetal ultrasound course. That is why he's having this question: how to diagnose partial agenesis of corpus callosum. In partial agenesis of corpus callosum, first of all, we have to identify the corpus callosum. How the corpus callosum is looking like? Corpus callosum is having, first of all, you know, the body genome. Let me go to the slide, because without slide it is a bit difficult to make you understand. Otherwise, I have to take the whiteboard, which is a lengthy process. So let me go to the yeah, I am already going there. Wait for a minute, not a minute, 10 seconds only, and we will be there on the corpus callosal slide. First of all, I have to identify a corpus callosum, and how to identify a corpus callosum. Probably you are now clear with the sections. That is the mid-sagittal section, complete mid-sagittal section for the corpus callosum. Yes, I got it. So in our hair, what we are seeing, first, make a habit of getting the splenium, body, genu, and rostrum. So get all these things. Probably it is not sharing. I am sharing this. Yeah, got it? So no, this is not that slide. So I'm going back. So there is some. Got it? Yeah. So this is the corpus callosum over here. In this corpus callosum, there are parts. There are parts of this corpus callosum. As you now know that there is a splenum, there is a body, there is genu, and there is a rostrum. Sometimes you may see this part and this part will be missing. That is partial agenesis of corpus callosum. Now, the point is that when we are putting color, we are seeing a pericalosal artery on this corpus callosum like this. The question is that if I will put a color, I am giving a lengthy answer. The question was that if I will be putting a color, pericalosal artery, if seen, means that corpus callosum is there. Yes, you are partially right. What I mean by partially, I will explain. In case there is complete artery, pericalosal artery, it means that you are having a corpus callosum. But what if I am having a partial agenesis? I will be seeing pericalosal artery from first point, maybe up to third point, but no way it will be on the fourth point, because what will be missing over here is the fourth part over here. Now see, and correlate this corpus callosum over here. First is the rostrum over here. Now see, this is the rostrum. This is the rostrum. This. So why I am skipping between these? Because I want you to correlate this picture on ultrasound. So first will be the rostrum over here, then will be the genu, then will be the body, and the splenum. The fourth part may be missing. So the answer to your question is that I have to rely on 2D ultrasound more when I am talking of partial agenesis of corpus callosum. And if there is complete agenesis of corpus callosum, then neither I will be seeing it on grayscale, nor I will be seeing a pericalosal artery. So I am very happy that people are now understanding these points, and they are getting matured day by day. I'm very happy. Now, the last question was that V-mole and GTD. I told you that we will take a separate session for this molar pregnancy. And meanwhile, there were some questions from Dr. Neha and others, which is not in the list, but still we will take this. Now, somebody has posted on our WhatsApp. We are having a dedicated WhatsApp group for each and every batch, where these candidates are posting these questions. One candidate is posting the question in probe movement. How can we define a broad movement is for which disease, and narrow on which disease? Please elaborate. Or this broad and narrow. Now see, what that candidate is confusing, that the sliding of the probe is different for different organs. No, that candidate is taking the knobology now. So once you will go to the abdominal class, you will see that this sliding on narrow and sliding on broad, sliding on narrow and sliding on broad, which is a part and parcel of physics and machine settings, is not for a specific organ, that one organ has to be scanned on the broad and another on the narrow. No. So this is not organ specific, I will say. Second question from the same candidate is, kindly tell me the tumor in abdomen, what will be image darker white? Usually tumors, if malignant tumor, now see, if malignant tumor, it will be hypoechoic, but this is not a golden rule, but usually we are seeing malignant tumors as hypoechoic. Hypoechoic means that this will be more of darker side. Now, the third question from the same candidate, who has not yet completed the abdominal ultrasound. I am telling that with a surety, because the third question is that fatty liver grade third image will be same of grade 1 or different. 101%, this candidate has not even touched the abdominal ultrasound. He is yet taking the physics and machine settings only, because this question will not arise if that candidate will take the abdominal ultrasound, which will be subsequently activated for him. Of course, grade third liver will have a different picture. Now, how the picture will be looking like, that is the part and parcel of the abdominal ultrasound. So, meanwhile, Dr. Nidhi probably posed the question that how to differentiate a TO mass from a ovarian pathology, I mean ovarian mass. Now see, if there is everything involving TO mass, what is this? Tubo ovarian, it will be involving each and everything. Each and everything means that tube as well as ovary. Then in case of TO mass, you will not find an ovary. I'm repeating, in case of a TO mass, if it is TO mass, you will not find an ovary. And in case you will be finding a mass and a normal ovary, then it is not a TO mass, that is tubal mass. Now, if you see a mass which is arising from the ovary, that is ovarian mass. It's very simple. So, do I have more questions? No, probably I don't have more questions. Yeah. In case anybody is having any question, I will be waiting for next 30 seconds to raise the hand. And in case I will get the raise hand option, raise hands, I will entertain one raise hand. Usually what we are doing, we are not taking questions this way. What we are doing, we are taking questions in our WhatsApp group. Then we are making a list of these questions like this. Then we are discussing. But I am giving today you an opportunity to raise the hand and discuss anything with me. I will be waiting for next 30 seconds for raise hands. So you can raise the hand in case you are having any question.
Meconium in the bowel.
Wait. Yeah, please first tell me your name and the course which you are taking right now, so that I can have an idea what is delivered to you, and accordingly I will make my answer short or very lengthy.
Yes, sir. Yes, sir. Yes, sure, sir. So I am Dr. Vinoda from Viluppuram, Tamil Nadu. At present, I'm undergoing fetal sonography classes.
Have you
sir.
completed the fetal ultrasound course?
No, not yet, sir. Not yet, sir.
Not yet. This is
Fetal sonography, I'm doing it. Part of the fetal abdomen and fetal head, I'm doing, sir, right
now.
now.
See, if you are posing a question, you have to first complete the topic. Then you have to pose the question. Am I right or wrong?
Yes, sir.
No.
Sure, sir.
Anyhow, I will entertain your question. Let me know what is your question.
Sir, suppose I am scanning a fetus in the late 3rd trimester. Suppose she's due next week or next 10 days. She's coming to me and I'm scanning a baby. Is there any finding apart from the fetal biometry? Are there any findings in the fetus to say it is mature or not?
Okay, got it. So you have not only to see the fetus. When you are talking of this maturity, you have to see to the placenta also.
Okay.
If
sir.
placenta is having grade 3rd,
Okay.
please
okay,
listen
sir.
carefully, don't get confused. If placenta
Yes,
is
sir.
having grade 3rd, then most likely you are
Yes, sir.
dealing with a near-term pregnancy. Yes or no?
Seconds. Yes,
But
sir.
this
Yes,
is not a
sir.
golden rule.
Yes.
This is not a golden rule.
Mm.
Now,
Mm.
if there is a
Golden
28
rule,
weeks
yes,
fetus
sir.
and the placenta is advanced degraded,
Yes, sir.
what it means then?
Can be an IUGR plus.
IUGR. That is why I told you, hold on, don't make it as a golden rule. So the point is that you have to see to the fetal biometry. Of course, you have to see, but you have to see for the placenta also. Point number 1. Point number 2, if there is clear fluid and if sometimes there are some dark spots, I mean these hypoechoic dots over there, what it means, what I'm dealing with in amniotic fluid, I mean.
The vernix.
Yes. So the conclusion is that you don't have to restrict your eyes onto the fetus only. You have to see to the amniotic fluid. You have to see to the placenta also. Then you can decide the maturity. And one more important thing. One more important point is that, now see,
Yes, sir.
is your name, sorry, Dr. Vinodia, right? Is your name Dr. Vinoda?
I'm Dr. Vinoda, sir. Vinoda.
Yeah. Now see,
Vinoda.
Dr. Vinoda.
Vinoda, sir.
Okay. If we are scanning a Chinese fetus, try to understand the concept first. If I will be scanning a Chinese fetus, and if parallelly I will be scanning a South African fetus,
Yes, sir.
the bones of a Chinese fetus, I mean the femur length, will be
Yes, sir.
shorter than a South African fetus. Am I right or wrong?
South Africa.
Now, it depends
Yes.
where I am scanning. So
Yes,
this way,
sir.
I have to
Yes,
keep
sir.
the
Yes, sir.
potential in my mind also. Not always the femur length will
Yes, sir.
be matching with
Yes, sir.
the gestational
sir.
age. That is why in
Gestational
each and
age.
every machine, there is
Yes,
plus
sir.
minus 1 week, plus minus 2 weeks. So you have
Okay,
to
sir.
take in account multiple things before concluding on to whether this is a near-term fetus or this is having any other maturity wise. You will decide accordingly.
Yes, sir.
Dr. Abu MD.
Thank
Dr.
you,
Vinod, I'm
sir.
lowering your hand.
Yeah. Yes, sir.
And
Thank you,
I'm
sir.
muting you so that we can avoid the disturbances. Dr. Abu MD, I am sending you an invitation. I'm sending you right now. So if you will be accepting it, I'll be taking your question also. Yeah, Dr. Abu MD.
Good
Yeah.
evening, sir.
Yeah, good evening.
Sir, actually, I have a question that, sir, in every machine, the setting are same or it is different, sir?
Okay. So the question from Dr. Abu MD is that whether the settings will vary from one machine to another or the settings will remain same. Is that your question,
Yes, sir,
Dr.
yes.
Abu?
Yes, sir.
Now, if I will give you now reply to my question. If I
Yes,
will
sir.
give you, are you driving a car? Any car?
Yes,
or
sir.
no?
Yes, sir.
Which
Yes,
car you are
sir.
driving?
I have, sir,
Which
uh,
company's car? Company's car.
sir, I have Baleno.
Baleno. Okay. You are driving a Maruti car, right?
Yes, sir.
Now, if I will give you a BMW, will you able to drive same day?
Yes, sir.
But
No, sir.
you will first see what wire is. Wire is clutch, wire is the brake pad, wire
Yes,
is
sir.
the gearbox.
Yes, sir.
Straight away,
Yes, sir.
you cannot drive. Now, being a driver, you are having a
sir.
license, you know that this is clutch, this is the
Yes.
brake pad, this is the
Yes.
accelerator. But
Yes,
the
sir.
same thing will not be in a BMW or even a Mercedes. If you are driving right now Mercedes, if I will give you a BMW, the same things will not be in place in a car.
Yes, sir.
Now, my question to you, counter question to you. How you are expecting a GE machine to have the same knobs as of Philips? Same knobs I'm stating, not settings, same knobs. Some
Yes, sir.
knobs on GE machine will be on the right side, but
Yes,
the
sir.
same knob in other Philips machine or Samsung machine will be on the left side or onto the upper corner. But
Yes, sir.
when I am talking of settings,
Yes, sir.
I have to first make myself understand that this brake in the car is to stop the car. This clutch
Yes, sir.
is to press when I am changing the gear. Then,
Yes.
irrespective of whatever car I will be having, I will be able to drive that. But first, I will get familiar with the thing. Same is true for the machine. You have to now see what you have to see, keep in mind when you are scanning. Frequency, freeze, defreeze, dual image, dynamic, everything what is discussed with you in physics and machine settings. Then you have to search for that knob in your machine.
Yes, sir.
You got
Sir,
it?
yes, sir, I got, but like you told me, like in the right side and left side is okay, but the function will be same, sir, na?
Function will be same. Frequency.
Yes.
Now see, the brake will be same for BMW as well as limo.
Yes,
So the frequency will be same, be it a G machine or a Philips machine.
Yes, sir. Yes, sir.
The function, the
Yes, sir.
settings will be same settings, but knobs will be different.
Yes, sir. I got
Done?
it, sir. I got
Okay.
it.
Anything else?
Thank you, sir. No, sir.
Okay, welcome. So this was all for now. We are taking these types of questions on for our registered candidates at regular intervals. We are sending these. We are adding the candidate in a WhatsApp group where he will be in contact with us and sending us the questions at a regular basis. Thank you very much. God bless all of you. See you next time.